Next up, we have the live surgery by Dr. Chitra Ramamaurthy, ma'am. Over to you, Sneha, ma'am, in OT.
So we have a live surgery that is going to be performed by Dr. Chitra Ramamaurthy. She's a dynamic lady who leads with confidence and inspires with inspiration, with a purpose. And she will be performing live surgery, that is Smile, on Zeiss Visumax 500. Over to you, ma'am.
Good afternoon to one and all of you. Here we are going to be talking about doing Smile on a young girl, Kavya Shri, who has a refractive error of minus 4.5 diopters. Now essentially we all know Smile is right on the top in the refractive armamentarium, and it has been here for the last 1.5 decades, and it has continued to evolve and improve in its nomograms, in its energy settings, and today we are able to do a very easy lenticule removal with a very optimal end result for all our patients. I would be doing this procedure on Visumax 500 Hz machine. This has a laser which works in the femtosecond laser, which works in the infrared range of 1053 nanometers, and it's a process of photo disruption here as against the photo ablation which happens with the excimer laser. In the excimer laser, it is centered, the treatment is centered on the pupil center, whereas here the treatment is centered on the visual axis. So in fact, because of this, even small decentrations, if at all were to happen, it is very forgiving in its result. So basically here we are fashioning out an aspheric lenticule. The thickness of the lenticule can be as little as 10 microns to 30 micron. That thickness could be increased based if the refractive error corrected is very small, supposing a -1. You could start off with a lenticule thickness of 30 micron, and these are uniform planar lenticules, so it does not have a refractive impact. And as I would like to, the other important thing is you can manually mark for cyclotorsion compensation when you are doing a cylinder correction. And here we have, in this particular patient, the optic zone is 6 millimeter, and the cap size is 7.3 millimeters. If there were astigmatism, we would have created a transition of 0.1, which is not needed here, and the cap thickness is 110 micron, and the energy setting is the important thing, which has been beautifully optimized in the Visumax laser, and going further to Visumax 800, wherein here it is at 500 kilohertz, there it is at 2 megahertz. So basically, coming back to my machine again, normally the energy offset is slightly variable with different machines. Here the energy offset has been set at 26, and the spot and track distances are specific to the cavitation bubbles, which again varies from machine to a smaller extent. You try to have an energy of anything from 120 to 150. Here the energy is 130 millijoules in this particular patient. The energy mode of laser delivery could be on a standard mode or an expert mode. So we all know that cavitation bubbles are being created by photo disruption, and you are separating it by separating it with the spatula, separating the cap from the overlying cap, or lenticule from the overlying cap and the underlying bed. But it could be done on a standard mode or an expert mode. The standard mode, the spots are very closely aligned together, so that the dissection is good. But because of this, the photo disruption takes a little longer time. Whereas in the expert mode, the spots are little widely spaced out, but the dissection would be a little tougher, but it would be a faster dissection. So I've told you about the frequency of laser, I've told you about the energy offset, I've told you that it is centered on the visual axis. So we'll go on to the patient data. Let me get on. Yes, can you? Just 1 minute. Or would you just want me to say? Okay, the refractive error is 4.5 I said, the cap thickness is 110, and 6 millimeter is the optic zone, the residual bed is over 300, and the incision width is 3 millimeters. And now as I go on to start the treatment, I would like to keep my patient's head a little away so that the nose doesn't abut on the optical device, because The vacuum is actually quite low. It's a corneal based suction, and the vacuum is low. It is quite gentle. Of course, we need to keep the attention of the patient totally on to the procedure, and unlike the other machines, so we need to be talking. So once the laser delivery starts, I would have to concentrate on Kavya Shri. Kavya, I had to tell all of this. Now you just relax. I'll be taking care of you. Okay? No, no, no. Not now. It's in 50. Keep looking straight at the green light. Keep looking straight at the green light. You will feel something touching your eye. Don't jerk at all. Remain completely still. Remain completely still. I'm applanating the cornea. It's centered. Keep looking straight. You're doing well. The green light will disappear. The treatment has started. Just keep looking straight. The green light will disappear. You're doing quite well. The inner spiral in. The lenticule cut is happening, and then the light would disappear. Keep looking straight. Then the side cut has happened, and then going on to the cap cut. Keep looking straight. You're doing very well. 30, 40, 50, 60, 70, 80, 90, 95, 96. Doing very well. The suction is over. You can see that here the OBL is a little dense in this particular case. Maybe she has been lying down for long. The cornea could have got bright. So the dissection might be a little difficult. Can the stool come down a little more? Can the stool come down? Little down. So just keep looking straight. So we have to separate, go above the lenticule and go below the lenticule. Decrease the magnification. And now I will take it above the lenticule. Sometimes we could miss out this. So you have to separate the tissue bridges, go right end to end, gently and slowly, keep the eyeball firmly fixed, and then identify the deeper plane. You will feel some resistance, so you know you are on the deeper plane. Move a little to the right, a little to the left. You want the lenticule to be anchored, so then you move it, separate it completely on this side, and then go back and try to separate it completely. Try to spread it out. Hold. And then go in and grab the lenticule. Take it just like you will take the rexes and pull it out. Now, when you are doing this procedure the first time, you need to spread it out to see whether you have removed the lenticule in toto. And once you have confirmed that it is done, it's out. So then what I would do after this is, earlier for some time I used to irrigate the interface, but now I don't do that. So I would just wash it and then just stroke it down, and that's the end of the procedure. Went off very well, Kavya Shri. So anything to ask at this point of time? Nobody has anything to ask? Any questions?
I think she did an excellent job and showed all the details in the dissection as also as to how to get the best out of it. Any questions or anything?
So basically, when we do smile, in our setup, we ensure even if the corneal thickness allow, we go up to only 8 diopters when we are treating on any corneal based refractive surgery. Beyond that, we go on to phakic IOL. And again, the lowest which we have corrected is even up to 0.75 onwards. And patients do very well after the procedure. And the Visumax 800 was another very major breakthrough which has happened, which has even a centration check, the cyclotorsion compensation, and the speed of the laser here. That the dissection laser pass was 29 seconds, whereas in that I think it's only about 8 seconds. So it's a way forward, and Smile as a technology has really matured. It is there now in different platforms which are all fighting to do well, but Visumax is truly an ace machine.
Thank you, ma'am.
Any thoughts on the cap thickness?
The cap thickness here is 110. It could be varied from 100 to 120, but largely it is kept at 110 micron. Now there was a little more OBL here. It felt so, but the dissection was so very easy. Thing is, this dissection could really be a little variable machine to machine. That's why you need to see a few of your procedures and titrate to your energy settings. The other important thing is even the corneal biomechanics of the machine would decide whether it's a thicker cornea, that would decide whether you're going to get more OBL, the intraocular pressure variables. There are a lot of small minuscule variables which will decide whether the OBL is going to be a little more dense when there's separation. But in the early days when you remove the lenticule, it's very important to spread the lenticule out to ensure that it's totally removed, which 99.99% it is always like that. But these are just some things which I'm trying to explain. It's a fairly simple procedure. I don't think there's too much to be asked on that. Anything else, or shall we move on to the next procedure?
Next
Thank
procedure.
And of course, I would really like to thank Naren and his awesomely wonderful team here. It's just unimaginable. As soon as you get off from the car, you're received by a person, and at the lift by some other person, and on to some other person, and somebody is offering you lunch, somebody is offering coffee. Believe me, I wonder whether any of us can scale ourselves to the level of warmth and hospitality. I think 3 cheers to Naren and his team. Hip hip hooray. I think they deserve a big clap. Yes.
Thank you very much, ma'am.
Thank you.